Hello, Dr. Hamadani. Thank you for joining me today.
It's an absolute pleasure to be here, Chrissy. Thank you for the kind invitation.
So, for those who are new to IMCAS and the IMCAS community, who are you and what do you specialize in?
So, I'm a plastic surgeon from Palestine. I work in a few fields within the broad specialty of plastic surgery. So, I work on lipedema, which is a disease of abnormal fat metabolism and distribution in the body. And I specialize in treating that, including surgically, which is a specialized form of liposuction. As an extension of that, I use a lot of energy-based devices because we use energy-based devices to improve the skin after lipedema surgery. But I've expanded my use of energy-based devices towards scar revisions, which is a big part of what I do as well, and also facial rejuvenation, so aesthetics more or less. I treat hair disorders and I do skin cancer surgery. So I just focus on those things so I can really provide the best treatments for my patients.
To have gotten to where you are today, what can you share about your educational and professional background?
Yeah, sure. So I did my undergrad pre-med in Canada and then medical school in Canada. And I did my first few years of surgical training there. I finished the equivalent of what's called the MRCS in the UK. So the first sort of level of surgical training in Canada, we call it POS. Spend a little bit more time doing research in trauma surgery and emergency respondedness in low income settings. So that was where my research was focused on. But then I recognized early on that I wanted a better work life balance. I wanted to move away from Canada back to where I'm from originally, which is the Middle East and the Mediterranean environment. The climate fit me better. So to do that, I chose to kind of focus more on cosmetic and a little bit of reconstructive surgery. And I started to really develop my skills in those fields. And I did training in a multitude of locations and with many different mentors and experts. Returned to my country of Palestine, got all of the necessary certifications and documentations. And for the last 10 years, I've been practicing in my city, which is called Ramallah. A lot of your learning is sort of structured and very classical medical education. But the real learning happens, I think, by seeking out people who do what you want to do and through a vocational kind of model. I mean, surgery historically and any procedural specialties within medicine historically were vocational. They weren't even part of the medical unions. In the UK, surgeons are called Mr., not doctor, until today, actually. They were part of the barber union for many, many years and only joined the medical union in the latter part of modern history. So, this vocational kind of mentorship based educational model is really what serves everyone who wants to do this in the best fashion. So, you need to seek out mentors and you need to get that one on one experience and spend time in what you want to do. That's the best way.
So, that brings something to mind for me. How do you go about that? Even in your own experience, how did you identify people that you wanted to learn from?
It's very difficult in most cases to know exactly what it is you want to do when you're starting out. And now I'm addressing people who are near the end of their medical training and they're kind of thinking, do I want to do something surgical, more dermatological? Do I want to do just aesthetic medicine? You have to figure that out yourself and see what gives you the spark. Once you've identified the spark, then it's really what you put into it. You get out of it what you put into it. And I left no stone unturned. I traveled the world. I spent time in France, Italy, Tunisia, Australia, South Africa, Athens, Italy, honing these skills through formal educational encounters and through informal educational encounters. And then when I returned and had my credentials recognized and had to, do the necessary examinations and get my board certification, I realized that a lot of what I learned for the purposes of the exam, I wasn't necessarily going to use in my day-to-day practice. But I was very glad that I sought out mentorship early because then I was able to get the necessary certification, but immediately start in the area that I am passionate about. The best advice I can give for people just starting out is honestly go to conferences. It's the best and easiest way. Organizations like IMCAS played a very big role for me early on. I was starting to attend the conferences. I was starting to watch IMCAS Academy online and started to see through lectures and through panels and through interactions the possibilities of what I can accomplish. And then identified the different mentors that I wanted to work with worked out how to go visit them and spend time with them and so on. And I'm talking about years ago. Today, now I'm honored to be a faculty at IMCAS. So it starts like that. So 90% of it is showing up. So go.
Quite honestly, I found that personally very inspirational. And at the risk of sounding cheesy, you are a prime example of what the goal of IMCAS is, to provide resources to get to the highest level you can in your expertise with respect to scientific integrity, evidence-based
Therapeutics and science and care. Yeah.
with patient safety in mind, and just hearing, the shout out to Academy, things like that, that it helped you.
Big time. In fact, it changed the way I practice. You see, when I was doing my niche trainings, they were very focalized. So my liposuction training was really on liposuction. And some of the injectable training that I got was on really classical ways of injecting the face. 2015, 16, when I started to attend IMCAS meetings and then the online resources became available, I was watching videos regularly. It gave me an advantage in my market because I was now hearing from world experts and getting access to knowledge that wasn't readily available to some of the other physicians who were practicing. And so it helped me stand out a little bit. Then at the end of the day, the important thing is we were able to help patients accomplish their goals or treat certain conditions in a more efficient fashion. But the learning that's available on these kinds of platforms was simply unthinkable a generation or two ago. So it's revolutionary. It's very high quality. You're hearing voices from all over the world. IMCAS Alert was an integral and important part of this personal growth professionally, because I started to visit the forum regularly and research around the questions that were being asked and learn from them. And what I realized was happening is I started to develop a bit of knowledge around these issues. And eventually, I think 2 or 3 years later, I was asked to join as one of the coordinators. So I am exactly a prime example of how really if you just show up and do the work, many doors will open for you. A part of it is obviously luck. I'm very lucky. And a part of it is the nature of the organization and how priority number one is always education and interaction. And over the years, the people I used to learn from have now become my friends. And during panels, we're joking and laughing, and you can see the young doctors get more and more inspired. So I think it's integral for ensuring safe, evidence-based, progressive knowledge and clinical applications.
So to start our conversation today.
Oh, all of that we haven't started yet?
No, the topic at hand,
All right.
I mean, not to discount all of the very interesting introductory part. So one of my more specific questions, I can phrase it that
Yes.
way, is what would you say are the unique challenges that you encountered managing scars following body contouring procedures in patients in the Middle East?
Oh, that's fantastic. Actually, the Middle East is unique because we know that darker skin types tend to scar more poorly. Whiter skin types or less dark skin types are more or less thought of to be non-scars generally. I mean, there are exceptions. In the Middle East, we're right in the middle, and it can kind of go either way. And the issue there is also, I think that there are multiple factors why that is the cause or that is the case. But I think in general, you can have somebody who doesn't scar well, and you can have somebody who scars very well, and you can't really predict because it doesn't always correlate with the skin tone. There are multiple factors in terms of our skin thickness, oiliness, how much ceramides we have. The barrier that we have is very, very different. So what I've learned and some of the challenges I learned initially, surgically, I use different kinds of sutures. So I use non-absorbable even for my deeper, the very deep closures I use absorbable, but for my middle to superficial closures, non-absorbable. And I had to become creative very quickly in terms of managing potentially poor scars early on. There are some studies and there was some literature that I picked up from IMCAS around sort of preparing the skin prior to surgery using lasers or certain injections, and I didn't really help in my population. But instigating these interventions early after surgery has been important. Some tricks that we use are botulinum toxin. This was a big theme in this Congress as well because there's a lot of studies around it now. So we tend to inject some botulinum toxin around week 4 to 6 when the myofibroblasts are starting to accumulate. And we are relatively aggressive with early pigmentation. So we start Q-switched or topical whitening relatively early. And if a scar is appearing to be hypertrophic, but it's within the scar boundaries, we give it a little bit of time, maybe some silicone. But if it starts to show that it wants to spread a little bit from the boundaries, and again, this is sort of like a scar that's on the spectrum between hypertrophic to keloid, we start injecting steroids or 5-FU very, very early. That's obviously for the surgical body contouring. We're doing a lot of non-surgical body contouring as well, which means we're using fractional radio frequency. So I'm a big RF expert, and as a disclosure, I am a key opinion leader, and I run the training for InMode, which is an RF company, but that's my expertise there. So I use a lot of internal bipolar RF. We don't tend to see that kind of scarring internally. We don't tend to see the fibrotic response that we see on the surface of the skin when we deliver these energies deep. So there we're okay. And when we're doing non-surgical, the access points that we use to do the lipo or to introduce the RF are much smaller, so they're easier to manage. But those are some of the principles that we think about and we're careful about. Obviously, avoiding sun exposure as well, hydrating the scar well, and so on.
So, how do ethnic and skin type variations influence your approach to wound healing and scar prevention?
Again, the more dark or colored the skin, the more likely it is that you may face trouble. Again, it's not a universal rule. Some people are scarers, some people are non-scarers, but the main element is we have closer follow-up. So when I was working in North America and in some European locales, sometimes the patients aren't brought back for a month or a month and a half. They're brought back initially that first week, and then they may, be left for the next couple of months or 3 months. We can't do that. We have to have much closer follow-up. So we see the patient the first 6 weeks almost every week. And we're monitoring how the wound is healing, and that we have even distribution of the tension and so on. And it forced us to change our practice in terms of having the necessary modalities that we may need to use if scarring is going to start taking a bad course available. So those are the two ways.
Okay. Can you discuss the role of laser and EPDs in improving post-surgical scars?
Absolutely. So that's an area very near and dear to my heart. We know that heat, different kinds of energies, release something called heat shock proteins, and these can lead to a variety of regenerative effects within scars and within the tissue. So almost all of my scar revision sessions will combine different energy-based devices, in addition to some pharmaceutical modalities, some injectable materials as well. But the introduction of these technologies has given us the ability to improve scars beyond what we were able to do before. And you have to have a variety of tools depending on the scar depth, the scar type, skin color of the patient, and so on. But they've given us a tool that is really helpful, especially when the scar is early. So we can now sort of intervene at a much earlier level during the maturation process and get some phenomenal outcomes.
Okay. So then what regenerative medicine techniques are currently most effective for scar modulation and enhanced wound healing?
Look, there's quite a few of them. It's a big and very broad field, regenerative medicine. We're still learning a lot. Just at this conference, I had the chance to speak with some world experts on this topic, and they're still in the middle of so many studies trying to assess where things are heading. But there are a few sort of key ones that have emerged over the last few years. Some are autologous, so that means you take them from your own body. So things like nano fat or stem cells taken from fat can have a potential regenerative impact on the scars. To be honest with you, I personally haven't seen much from this technique, but other colleagues have. Exosomes is another one. And again, this is also a very broad topic because there's different kinds of exosomes. Some are derived from human tissue, some are derived from plant tissue, some are derived from fish. I guess fish is an animal, so animal tissue, and so there's a broad spectrum, and now you have companies emerging in the States especially that can develop a specific line of exosomes that have like a specific character of signaling to lead you down a specific pathway of remodeling, which is fascinating. So we'll have to wait and see how that evolves. But I also think energy-based devices, in a way, are their own regenerative tool because heat and how you deliver it can also lead to different outcomes in the tissue. And so delivering heat a certain way will have a certain effect. Delivering the same heat but in a different way can have an alternative effect. And I think the future is how we combine all of these things together.
What are the best practices for minimizing scar formation during and after body contouring surgery?
So body contouring surgery that is purely surgical, like an abdominoplasty, where you actually have a scar, the key component is not having any tension on the scar and having a flap that's thick enough that it won't die, right? That has good blood supply. Because horrible scarring can occur if you develop poor healing issues or healing complications in that scar. So to distribute the tension, you need to do a very good surgery. And we have tools that are emerging outside of the EBD market that are special dressings and special, apparatus that can actually provide more support for the skin as it's healing. Then it's really a protocol of when do you introduce interventions if the scarring is not going as beautifully as you want it to. And there it becomes, the use of these injectables. Some people are using polynucleotides, which is a part of the regenerative spectrum of medicine. Some people are using toxin. I tend to combine a variety of things together. And then when needed, also introducing the energy-based devices to try to kind of remodel the scar early.
Okay. And could you share insights on patient compliance challenges with postoperative scar treatments?
Yes, there are some things that the patients like to do, some things that the patients don't. In general, in cosmetic surgery, so body contouring surgery, my compliance is pretty high because the patients have paid a lot of money and they're motivated to do this. And it's usually men or women who have accomplished a lot in life and now want to kind of regain some confidence. I struggle more with my acne scar patients and patients who have traumatic scars because these lesions have been a part of their life for a long time. And there's some psychological struggle within them. There's a part of them that wants to treat them. There's a part of them that, in a way, is not hopeful that they're going to get treated. And so sometimes that can create what we call cognitive dissonance, and they won't comply as much. So there is the challenge there. So what we try to do to improve this is to have frequent visits with a lot of talking. There's a lot of talking therapy and scars, lots of talking therapy. I do more talking therapy sometimes than I do procedures because my procedures, I tend to space them apart to give a chance for the tissues to remodel. But in between, I'll bring the patients in and sometimes they'll come in and won't do anything. I'll tell them, come in, we might do something, we'll see. And then when I see them, I see that they're still healing. And I say, listen, we're not going to do anything today, but how are you doing? Are you complying with the creams? Sometimes they are, sometimes they're not. They need a little bit of a nudge. There's a lot of psychological support that is needed to ensure compliance and trying to create a really tailored plan for them and explain why everything is important. I have found helped me a little bit with the compliance. It's never perfect, but these are some of the strategies I use.
Okay. Well, thank you for taking the time to sit down and share your expertise today.
Thank you so much, Chrissy. It was a pleasure.
Thank you.